Thank you. So we'll be changing tack to diabetic macular edema. So the approach I've taken is to basically first talk about the current basic principles from the clinical trials that govern diabetic macular edema treatment. Then looking at the factors that one needs to assess, especially in the tougher cases. And then that would decide how to strike. And then a quick look at the future directions. So the guiding principles from the trials, Resolve first showed us that ranibizumab unequivocally has high efficacy versus sham. The iconic DRCR protocol I trial showed us that ranibizumab laser combination is far better than laser or IVTA laser per se. And then deferring the combination laser was better than doing prompt laser. Why was this so? The equity graph shows us clearly that the ranibizumab arms, of course, were better than the laser and the IVTA prompt laser arms, but also that at 2 years, not at 1 year, but at 2 years, the deferred arm was better than doing the prompt laser. Also, unequivocally, pharmacotherapy is better than scores over the erstwhile laser which we were using earlier, and in the immediate as well as the late period. Interestingly, one notes that IVTA combination did almost as well as the ranibizumab laser arms up to 6 months, after which cataract genesis set in and then took away the results. And then we found that deferring laser, the advantage was also seen at year 3 and also at year 5 more recently. And this was also seen in the central retinal thickness graph, which shows that deferring laser arm was marginally drier. Early intense treatment, and this is an important thing, early intense treatment seems to reduce the treatment burden later. As you can see in these graphs in both the arms of the combination, in year 1, 8 and 9 injections, and then subsequently dramatically drops down. So it makes sense to obtain some sort of a grip on this disease by treating intensively, aggressively a little earlier. And also 33 to 43% of patients required no treatments at all in year 3. So that's a significant number. Definitely, there were higher safety issues for IVTA, as seen here. Incidence of elevated intraocular pressure glaucoma was much more for the triamcinolone combination arm compared to the other arms. Also, more than half the patients went in for cataract surgery at 2 years with triamcinolone, again not seen in the other arms. Rice and Ride trial gave us one very important piece of information that in untreated eyes, it's never too late for intravitreal anti-VEGF therapy. And this chronicity is not as big a deal as it is made out to be. This particular graph shows us this. You see the base, the line in white, which is the no treatment arm, hardly gets off the baseline up to 2 years. After which, when it is open for Lucentis treatment, it slowly starts, surprisingly, magically snaking up towards the ranibizumab arms. The CFT, central foveal thickness reduction arm, the OCD arm, also shows magically that once it was open for Lucentis treatment, this white line starts dipping down and coming close to the ranibizumab arms, which seems to suggest that even if something has not been treated for 2 years, a patient has not been treated for 2 years, and the macula looks fairly healthy, one should definitely go ahead and aggressively treat that patient. You might be surprised and see improvement in equity and OCT. The Restore showed us again that in lasered only eyes, again, something similarly, it's never too late for anti-VEGF therapy. Again, chronicity is not a big deal. It also told us that adding laser didn't reduce the ranibizumab retreatment rates, one of the major USPs for laser. This graph shows us this, that the blue line, which is the laser only arm, suddenly after 1 year, when open to anti-VEGF, starts snaking up again towards the ranibizumab arms. And indeed, by the end of the 3rd year, it actually catches up with the prompt laser combination arm, which suggests that it didn't seem to make a difference whether you added laser at the start or 1 year later. The results at the end of 3 years were almost the same. So again, do not hold your hand. If you find a patient who has been lasered and looks healthy enough, macula looks healthy enough, please go ahead and give that anti-VEGF injection and progress. This also shows us that the rates of retreatments were the same in all the 3 arms, suggesting that again, adding laser didn't seem to reduce the retreatments. The BOLT study showed high efficacy for bevacizumab for DME. The DRCR protocol T, the HOT study, which is being discussed all over, gave us again 2 very important points, that higher efficacy was seen for aflibercept or Eylea. Maybe I can use the cursor here. Yeah. Aflibercept was better than ranibizumab or bevacizumab only in the poorer vision group. That is the patients with less than 20 by 50 group. In the group which had good vision between 20 by 50 to 20 by 20, all the 3 drugs are more or less equivocal. So if you have a good vision patient, you can use either of these. Also, it showed us that bevacizumab amongst the 3 reduced macular thickness the least. So this graph shows us that the p-values were strong for aflibercept versus bevacizumab, aflibercept better than ranibizumab for equity as well as for CRT reduction. So now we'll go to refractory diabetic macular edema, which is the real challenge here. So the factors that one needs to assess is the clinical profile. In the eye, the fundus picture, the OCT fluorescein angiography features the best corrected acuity. One should also keep an eye on the fellow eye and also look at the systemic profile of the patient, and then finally rule out mascaraders. One should also look at the dosing history or posology, what drug was used, that will give us an idea how to proceed, the dosing strategy, whether that was optimal for that patient. And also in India, patient factors such as compliance and financial issues are a major issue for us. So in the clinical profile, I like to look at, I group them as mitigating factors and encouraging factors. With mitigating factors such as RP degeneration, macular atrophy, thinning, subfoveal fibrosis, macular ischemia, poor vision, for me less than equal to 3/60, loss of this ISOS integrity, signs of chronicity like outer retinal tubulations, and surgical issues like epiretinal membrane, VMT. If these are there, I would desist from going for an aggressive line of injecting. But if you find encouraging factors, which for me is like pure clean edema with or without subretinal fluid, suboptimal mission, usually ranging from 618 to 4/60, I would be encouraged to use a more aggressive line of injection. So the mitigating factors, some examples: macular ischemia, as you see here, subfoveal fibrosis, foveal exudates, outer retinal tubulations, which you see here, and foveal atrophy, and the surgical pathologies like vitreomacular traction and epiretinal membranes. Now the fellow eye vision is good. I think that's also important to note. If the fellow eye vision is good, one need not really pursue an aggressive line of treatment. One can desist. But if it's a one-eyed patient, then you would like to obtain as much vision as possible. Looking at the systemic factors also is important, whether the patient is on glitazones, patients are associated with macular edema, nephropathy is associated with macular ischemia, and also one needs to rule out hypertension, anemia, history of stroke, myocardial infarctions, and allergies. One needs to very importantly rule out the masqueraders. Hypertension, we know, can complicate or mimic in isolation diabetic macular edema. MACTEL has very often been confused with diabetic macular edema. X-linked retinoschisis can simulate diabetic macular edema, so these have to be ruled out. So if you have this, my general management mantra would be: first, initiate monthly anti-VEGF injections. If the patient is stable, that means equity or OCT is unchanged over 2 to 3 visits, then you can either go for a wait and extend or a treat and extend. Wait and extend, if you have these mitigating factors, you want to follow a conservative line of management. Treat and extend, if there are encouraging factors and you want to proceed with a more aggressive line of stand. Then in wait and extend follow-up up to 2 months. In this, inject and then extend follow-up up to 2 months. If it's stable, then you can extend follow-up up to 3 months. If it's unstable, I would prefer to move to a more aggressive, proactive approach, treat and extend. So if the dosing, if you feel, is inadequate, then switch HIT or taking and choosing another drug. For example, patient is on Avastin, you could try Accentrix or vice versa. Aflibercept, the new kid on the block, can also be tried in these kind of cases now. This is a case where the patient was on Avastin and then showed benefit with Lucentis, and you find that the converse is also true. Elderly pseudophakic IVTA can be tried. Younger patients can have an issue of rise in IOP. Ozurdex USP is basically vitrectomized eyes. It lasts up to 6 months, and prospective studies have shown improvement in acuity and OCT. The MEAD study showed that with 0.7 milligrams, patients improved in acuity with laser as well as other pharmacotherapies. This is the issue of IVTA being added to Avastin. I haven't found great results with that. So Helen and Wang in large prospective studies showed that adding IVTA to Avastin offered no real significant advantage. For diffuse diabetic macular edema, this is where combination therapy has a role. IVTA may be used. If you're using it with laser and anti-VEGF, please defer the laser. Laser alone can be used for non-center involving DME. The surgical issues, ERM and VMT, vitrectomy, and of course you need to rule out the masqueraders. The other alternatives are injecting at increased frequency, 2 to 3 weeks. I found this helpful occasionally, not always. Dose hikes, drug cocktails, drug holidays, limited vitrectomy with or without ILM peeling. I've had mixed results with this too. Future directions, we now have aflibercept, and reports are coming in. Protocol T has shown us great results. So aflibercept, as we know, is a soluble fusion protein. It has strong affinity for VEGF than ranibizumab. Unlike bevacizumab, ranibizumab, it inhibits also VEGF-B and platelet growth factor. So perhaps we have something here. Micropulse subthreshold laser, I've used the IQ 577. 5% duty cycle. You can paint the macula, contiguous treatment, causes less RP damage, and is seen having less tissue damaging effects on autofluorescence and microperimetry. So this is the summary of DME management. Anti-VEGF therapy is the mainstay. We have aflibercept coming in now, and this is generally the summary and synopsis. Thank you.